Welcome to The Explainer. Today, we are diving deep into the world of red blood cells. We're going to cover the whole spectrum, from having way too few, anemia, to having way too many, which is polycythemia. All right, so picture this. Your patient's complete blood count, the CBC, just hit the chart. This is probably one of the most common labs you'll ever order. But it's not just a bunch of numbers, right? It's the beginning of a story. And our job is to figure out how to read it.
And that story can go in two totally opposite directions. I mean, look at this. On the left, you've got these pale, kind of small cells from iron deficiency anemia. Then on the right, that's a bone marrow packed with fibrous tissue, something you can see in polycythemia, where there's an excess of red cells. So today, we're going to build the mental framework you need to tackle both of these extremes.
But first things first, before we can figure out what's wrong, we've got to understand how the system is supposed to work. And really, it's all about keeping things in this perfect, delicate balance.
The body has this absolutely beautiful feedback loop. Think of your kidneys as these super smart oxygen sensors. When they sense that oxygen levels are dropping, they send out a hormonal signal called erythropoietin, or EPO for short. EPO travels to the bone marrow, which is basically our red cell factory, and tells it, hey, ramp up production. More red cells get made, they deliver more oxygen, and boom, the system rebalances itself. It's just elegant.
Okay, so that's the ideal. But what happens when that super efficient, finely tuned production line starts to break down? Well, that's when we start seeing anemia.
You can really boil down the problems into three big categories. First, you could have a simple shortage of raw materials. No iron, B12, or folate means you just can't build the red cells. Second, the factory itself, the production line, could be broken because of a bone marrow disorder. Or third, the factory could be working just fine, maybe even working overtime, but the finished products are getting destroyed or lost faster than they can be made.
So let's get practical. You've got a patient, their hemoglobin is low. How do you figure out what's going on without just ordering a million tests? You need a logical path to follow.
This right here, this algorithm is your clinical GPS. And I want you to notice the very first fork in the road, the first big question it asks. What's the reticulocyte count? That one number tells you if the bone marrow factory is even trying to respond to the anemia. It's your single most important first clue.
And the logic is actually pretty straightforward. If the reticulocyte count is high, it means the marrow is working hard. It's pumping out tons of new, immature red cells. Why? It's trying to make up for cells being lost somewhere else, maybe from bleeding or from hemolysis, where they're being destroyed too early. But if that count is low, well, that points the finger right back at the factory. The problem is inside the bone marrow itself. It's just not producing enough.
Okay, so you've figured out if it's a production or a destruction issue. What's next? Your next big clue is all about size. We look at the mean corpuscular volume, the MCV, which tells us the average size of the red blood cells.
And this is so incredibly helpful because it lets us sort all the possible causes of anemia into three big buckets. Are the cells microcytic, meaning they're too small? Right away, you should be thinking about things like iron deficiency or thalassemia. Are they macrocytic or too large? Now you're thinking about B12 or folate deficiency. Or are they normocytic, just a normal size? This simple step dramatically narrows down your list of possibilities.
So the numbers are great. They get you in the right ballpark. But to really, truly nail the diagnosis, you have to go beyond the printout. You have to look at the cells themselves on a peripheral blood smear. And the difference can be absolutely night and day. On the left, you see these nice, healthy, round pink cells. But then look to the right. Those are the classic cells you see in iron deficiency. They're obviously smaller, that's the microcytic part, and they're paler, or hypochromic, because they're missing all that hemoglobin.
And different diseases leave their own unique fingerprints. Check this out. On the left, you've got spherocytes, these small, dense little balls that have lost their pale center. You see those in hereditary spherocytosis. Then on the right, you have target cells. They literally look like a bullseye, and they can point you towards things like liver disease or thalassemia.
There are a few of these cell shapes that you just have to burn into your memory. Sickle cells, obviously, are the hallmark of sickle cell disease. Teardrop cells can mean something is invading the bone marrow, and even the other cells give clues. See a hypersegmented neutrophil? That's a huge clue for B12 or folate deficiency. Every single shape is a piece of the puzzle.
Now, this is why looking at the smear is so critical. If you ever see these cells, these are schistocytes. They're fragmented red cells. This is not just some interesting finding. This is a 5-alarm fire. It is a medical emergency. It means red blood cells are literally being shredded as they move through the circulation, and that patient needs help right away.
Okay, let's totally flip the script. We've talked a ton about when the factory fails or can't keep up, but what happens when the factory goes into absolute overdrive?
That, my friends, is polycythemia, and it's exactly what it sounds like, the opposite of anemia. There are way too many red cells, which makes the blood really thick and sludgy, and that brings a whole new set of problems, like a much higher risk of blood clots.
And hey, guess what? Just like with anemia, there's a clear, logical algorithm to work through this. Once you've confirmed the red cell count is legitimately high, the single most important test you're going to order is a serum EPO level. That is the key that unlocks the whole diagnosis.
And the logic is beautiful, so think about it. If the EPO level is low, it means the kidneys are screaming, "Stop, we have enough red cells." But the bone marrow isn't listening. It's just producing on its own. That's a primary bone marrow cancer called polycythemia vera. But if the EPO is high, well then the marrow is just being a good soldier and following orders. The problem isn't the marrow, it's just responding to some other signal, like chronic low oxygen.
Whew. Okay, we have covered a lot of ground, from too few cells to way too many. So let's bring it all home. When you're faced with an abnormal red cell count, what's the core approach you need to remember?
It really boils down to this simple but incredibly powerful three-step approach. Step 1, start with the numbers on the CBC. Is it high or is it low? Step 2, use the retic count and the MCV to classify the problem and start building your list of possible diagnoses. And Step 3, go to the peripheral smear to find those specific clues that will tell you the real story.
Please always remember this. The machine gives you the data, but it's your eyes, looking at those cells under a microscope, that really piece together what's happening with your patient. So the next time a CBC lands in your inbox, what story are you going to find?